mechanical complications of acute myocardial infarction. So these mechanical complications are very rare. Okay. These mechanical complications are basically very rare, and even they are becoming less and less nowadays with the current intervention because of the early revascularization. So in your career, I'm not sure, you may see a couple of cases of them, or some of you may not see even a single case. So but it is better to know these complications and have always suspicion of these complications which may happen after an acute myocardial infarction. Basically, we divide these complications into the three parts, like rupture of the interventricular septum, which is called a VSD or VSR, which is the commonest one. And then second one is rupture of the left ventricular free wall, which is the second one. And third one is a papillary muscle rupture or necrosis. We'll discuss papillary muscle rupture because it is an acute event. And eventually all these mechanical complications lead to the cardiogenic shock, and the cardiogenic shock eventually leads to multi-organ failure, and then the sickness and eventually the high mortality and high morbidity rate. You can stop me anytime if you have any questions and we can interact. This is an interactive session, so.
Yeah, thank you, boss.
Yeah. So incidence and prognosis of mechanical complications. If you'll go to the
sorry, Dr. Shabir.
Yes.
In the book, it's mentioned in the key question, I think, and I'm not sure if in the Lawrence same or not. It's mentioned the free wall rupture is the most common complication. So anything changed recently, or
okay, I got your
different box.
Yeah. So that is what we are. This slide says incidence and prognosis of mechanical complications, which will answer your questions. So thrombolytic era, the complication rate has been reported up to 6%. Okay. Now after the thrombolytic, it decreased, and eventually after the PCI, it further decreased. Now, if you see, the PCI is very rampant now from last couple of decades. So last one decade or so, there is hardly any change. So the book mentions is a very old, references. You should always quote what is the reference. So the current era, it has decreased compared to the prehistoric era, which is reported up to the 6%. I mean pre-thrombolytic era, it is very high. Then now currently it is very low. Next, we'll see this paper, this article. I will suggest every one of you go to this article. That will answer your, Dr. Hussain, answer your questions. This publication has recently been in the 2019 in a JAC, and the title is Temporal Trends and Outcomes of Mechanical Complications in Patient with Acute Myocardial Infarction. Why did I choose this article? Because this article, if you'll see, it shows around, it shows 9 million cases. This is the biggest study or biggest number of cases which has reported the mechanical complications of the acute MI. That is why I choose this one. So if you see the STEMI is almost around 4 million, and non-STEMI around more than 5 million. So there is more than 9 million of acute MI cases were studied in this publication. So this is the biggest study which I come across on reviewing this article on the net. So what happens? So mechanical complications happen in 10,000, which is only 0.27%. Okay. And in the non-STEMI, it is there, but it is 0.06%. So mechanical complication can happen both in STEMI and non-STEMI. So Then when we subdivide these complications into the papillary muscle rupture, which is in STEMI, it is 0.05%, VSD or VSR, some publications write a VSR, it is a R means rupture, it is around 0.21%, and a pre-war rupture is 0.01. So the pre-war rupture is the least one. Similarly, in the non-STEMI, the pre-war papillary muscle rupture 0.01, VSR is around 0.04, calmness to 1, and the pre-war rupture is around 0.01. So if you go through the GRACE registry, it also shows mechanical complications are, which GRACE registry, which I didn't put a slide, it has around 60,000 of patients, which again shows mechanical complications are less than 1% and 0.9%. Most of the contemporary literature shows the mechanical complications are less than 1%. So when we see the temporal trends of these complications over a period of 13 years, this is an era of the PCI from 2013 to 2015, there is hardly any change. Over the last 13 years or more than one decade, there is hardly any change in the incidence or the rate or decrease or increase in the rate of the mechanical complications. In the STEMI, the rate is around, it was 0.2%, it is still around even 0.28%. It is, so no change. Similarly, if you see the mortality among ST elevated myocardial infarctions with mechanical complications, the mortality in 2013 was above 40%, and it is still almost same. There are some bumps, but there is no significant change of the mortality or the incidence of mechanical complications in STEMI. Similarly, when you see the non-STEMI, the mechanical complications are obviously low, 0.06%, it is still the same. And the mortality also, in non-STEMI, the mortality definitely low, it is around 24%, it is still persistent with 24%. So over the last more than a decade in the current of the PCI, though the overall incidence has come down, but it is static from last more than a decade. When we analyze this article more and do a subgroup analysis, in this you can see the STEMI patient is the most important risk factor for the risk factor for the mortality was the elderly people. So elderly people have high incidence of mechanical complications and even the death. So, sorry. Okay, you can hear me?
Yes.
Okay, sorry, something happened. So what is most important thing is STEMI, if you'll see the elderly people, they do a worst. Any surgery, but here again, it is the same finding, this, the elderly people, they do the worst, and the younger, they do, they have a less mortality. And similarly, the STEMI or non-STEMI, but elderly do the worst. But interestingly, in the non-STEMI, the females did a better. So the males were worse, but here it was females were worst. But overall, most of the publication is right that the females outcome is poorer than the males. But in this publication, in this article, the females in non-STEMI, particularly non-STEMI, they had a lower mortality. Okay. Then when we see these mechanical complications in patients after STEMI, they had a high mortality. Hospital mortality was 42%. They had a high cardiogenic shock, high kidney injury, high hemodialysis, respiratory complications. And these mechanical complication people, they had mechanical circulatory support was used almost 50% of these patients. So this is the highest mechanical circulatory support used in cardiac surgical patients who had a mechanical complication. This is in STEMI. When we see the non-STEMI, they also have the similar things. Though the in-hospital mortality of non-STEMI is lower, it is just 18%, but cardiogenic shock, acute kidney injury, hemodialysis, respiratory complications, and other complications are high, but they are lower than the STEMI. And again, the mechanical circulatory support was used in 24% of the patients who had a mechanical complications because of the non-STEMI. And STEMI, as we saw in the previous slide, it was 50%. When we did a multivariate analysis and see which factors affected the outcome of these patients, if you ECMO, what we call, most of the time, put a patient on ECMO, it doesn't make any difference. So ECMO it doesn't help the patients much. Basically, these patients are very sick. Maybe this is the reason they didn't do better. When I reviewed the literature, I didn't see most of the studies, because they are only case reports, most of the studies show that ECMO was a risk factor for the mortality. It didn't help. Similarly, in the non-STEMI, again, ECMO didn't help. Though the IABP is helpful, but ECMO did not help. So incidence in current era, when we summarize this paper, the ventricular rupture has a low incidence now, which is around 0.21% in the STEMI, 0.04% in non-STEMI. Papillary muscle rupture is 0.05 in STEMI. In non-STEMI, it is 0.01. Free wall rupture is 0.01 in both STEMI and non-STEMI. We summarize this paper. Mechanical complication in STEMI is 0.27%. In STEMI, it is low 0.06% with no significant changes over more than a decade. Similarly, in hospital mortality with these complications are 42% STEMI and 18% in non-STEMI with no change over a last decade. Patients with mechanical complications have a higher rate of in-hospital mortality, cardiogenic shock, acute injury, hemodialysis, respiratory complications. Use of mechanical circulatory support is high, around 50%, and they stay longer in the hospital. So, but the elderly people do worst, both in STEMI and non-STEMI, and in hospital mortality is higher in women compared to men, particularly in the STEMI patients. The use of mechanical circulatory support is around 50% in STEMI patients and 25% in the non-STEMI. Now we'll focus in the post-MI VSR. Then we will we'll focus on the ventricular fear rupture. Then the third will be the papillary muscle rupture. So first we will discuss about the post-MI ventricular septal rupture. We'll begin with a case report. This was one of our cases. He is a 57 years male. He presented with acute anterior septal ST-elevated myocardial infarction. He was diagnosed within 18 hours. Large anterior septal VSR was on echo. He was in cardiogenic shock. He was intubated, ventilatory support, and he was started on vasopressor inotropic support. He was anuric, started on furosemide without any much help, but he was not put on ECMO. Just we put an IABP. I think I didn't mention it. He was on IABP. So during our presentation, just remember this case presentation, because in the coming slides, we will keep on discussing this patient, what we did and what was the findings, how we did intraoperative, and eventually what happened to the post-op. So post-MI, by definition, post-MI VSR is an opening in the interventricular septum resulting from rupture of acutely infarcted myocardium. So incidence of post-MI VSR, as we presented this article first one in detail. As I was telling, the incidence showed in the other studies like Greece registry, it is 0.26%. In Apex acute MI trial, it was 0.17%. Gastro trial, 0.2%. New Jersey myocardial infarction data acquisition, it was 0.27%. In the shock trial, it was 3.9%, because all of them were in shock. So it was reported highest. So overall, if you will see the acute, this mechanical complication VSR is less than 1%, around 0.2% generally you can say. So historical background, first it was diagnosed in an autopsy case in 1847. Then it was clinically diagnosis was made in 1923. Then the surgical repair was attempted first by the Dr. Cooley. He did an post-MI VSR in 11 weeks after the myocardial infarction. The patient actually only died, I think, because of the pneumonia. Then further progress was made, and he approached, sorry, the coolie approached through the RV. So then the Key and Dobust, they did a left ventricular approach. Then the further progress was made, double patch method, and eventually Daggett. He did a very good job, and he lots of publications about the Daggett. He very popularized infarctectomy and patch closure. But the most popular nowadays is David technique, which is an infarct exclusion technique, which is we showed a very excellent results. And even in the Figura, he particularly from the Japan, they tried to repair the right atrial, but it is not so popular in the acute settings. Yes, it is popular in the chronic settings as we do in the pediatric cases. Percutaneous device closure post VSR is still evolving. Some selected cases can undergo a percutaneous device closure. What happens if we do not operate them? So nearly 25% of these patients will die within 24 hours, 50% in 1 week, and by 65% in 2 weeks, 80% in 4 weeks. 1 year survival is hardly around 5 to 20%. Spontaneous closure of post-infarction ventricular septal defect has been seen, but is very quite rare. This slide is from the Kirkland. It's reported in 1978, a good number of cases, 139 cases. So what happened during the first 1 month, almost 80% of the cases die. And then there is a gradual process. Even though they live, but they are usually having heart failure, particularly where there is a significant shunt. Or patient may be less symptomatic depending on the LV function and depending on the other coronary arteries and the amount of shunt across the defect. When do we diagnose? If you see the most of the trials, identification of VSR from infarction to rupture usually is diagnosed 24 hours, as we have seen in shock trial, gastro trial, and AMX, AMI trial. Historical data, as we were discussing before, pre-thrombolysis, it was diagnosis was established late because maybe we were not that aware of about this complication, but it has been diagnosed even up to 2 weeks. So, but recently, most of the trials have been diagnosed very early. So pathophysiology, morphological classification of this is simple rupture. Simple rupture, there is a direct connection between the left and the right ventricles occurring at the same level in both chambers. So there is a big defect. So directly blood goes from the left ventricle to the right ventricle. But however, there is a complex ruptures. They take a serpentinous course along the septum. Whole septum is necrosed. And so you have to reconstruct the whole septum here. This is one of our patients. I operated upon this patient. He had a whole septum. We have to put a big patch. So alhamdulillah, he did well. So what happens after the VSR occurs? So the blood goes from left and is shunted to the right sided, and then RV, so RV cannot take the volume load, so RV fails. So LV fails, so both ventricles eventually fail, and they develop a cardiogenic shock with multi-organ failure and eventually mortality and morbidity. So I think this is a classification. We'll pre-wall rupture. We'll discuss it not in VSR. We'll discuss in the pre-wall rupture. What leads to the VSR? So single vessel disease is a more risk. If you see more than 50% of the patients have single vessel disease in VSR. STEMI, if you have a big myocardial infarction, the chances of developing the VSR is high. Poor septal collateral circulation. If there is no collateral circulation, they have the high risk of developing the VSR. So LAD and right coronary arteries are the most common infarct-related arteries leading to septal rupture. I think they are equally involved around 50 to 50%, but 40% to 42 and 46% respectively in VSR in shock trial was reported. Anterior and inferior infarctions contribute roughly equal to the VSR burden. So anterior and posterior inferior infarctions, VSR are same, but in my experience, I saw most of the patients in the anterior septum. And most of the cases were the LAD, and most of them were single or two vessel disease. It has been mentioned in the books, like if you have a hypertension, diabetes, prior smoking, and prior MI, they have the less chances of developing the VSR. Probably the explanation has been given that pre-existing coronary, these patients already have some coronary artery disease, and which leads to development of protective collateral circulation. So the incidence of the VSR is less. But it is equally possible that these patients they are develop cardiogenic shock or pattern rupture, so leading to observational bias. So we are not sure, but overall, if you see the patient hypertension, diabetes, prior smoking, prior MI, they have less chances of developing the VSR. How do these patients present? The shortness of breath at exertion, it could be mild shortness, or they can be even a severe cardiogenic shock, or even a multi-organ failure because of late presentation. One of the important things is there is new cardiac murmur is nearly always present. So you should always put your stethoscope and listen to the murmur. It is very harsh and a hollow systolic murmur. It is heard in the left lower and on the right sternal border, the left sternal border, occasionally it is widespread radiation over the pericardium. The S3 heart sound is heard because of the heart failure. P2 is usually loud because of the increased volume coming to the RV. And you have to differentiate from the mitral regurgitation murmur. Sometimes it may be difficult, and clinical scenario may overlap. And there are some patients, around 20% patients, they may have associated mitral regurgitation. And so you have to be careful in diagnosing clinical grounds. I think everyone is aware of what happens after the cardiogenic shock. Features of right heart failure, of cardiogenic shock, what happens, lower limb edema, sacral edema, hepatomegaly, high JVP. There is a murmur of the tricuspid area. In the left, you will see the lungs become congested. There are crackles in the lungs, respiratory wheeze, apex gut is displaced, left heart side murmurs as we talk about. But in the both biventricular failure, you will see overall there is a cool periphery, cyanosis, orthopnea, and delayed capillary refilling. So how we diagnose it? X-ray chest, which is not
Dr. Shabir, boss?
Yes.
Kindly, this previous slide, if I'm in encounter with a patient with right side heart failure, clinical feature, is that will affect my decision for taking him for the OR?
Okay, this is a late question. Let us, so if you will concentrate on the surgery, no. If you'll go what we presented our case, let us go to the case summary. I will give the example of the same case. So he had a large shunt. He was in cardiogenic shock. So he had a large septal rupture. So his RV was more severely affected compared to the LV. LV was ejecting forward, LV was injecting the RV, but RV was acutely overloaded, and it was a severe RV dysfunction. So this is a mechanical complications. You cannot, if you wait for this patient and leave, he will, after 12 hours, he will have multi-organ failure and irreversible state. So his outcome is poor. So timing is very, very important. So RV, if you, there is a different case scenario. I think we'll discuss this in a case scenario basis. Otherwise we'll mix up.
Okay.
So RV should not, yes, it may not, depends on the scenario.
Okay, agreed.
There is no straightforward, because there are just case studies, 10 cases, 12 cases, big centers have done 25 cases or 30 cases, but overall it is a case by case basis. We'll put in a case scenario, what happens in the, you can ask, and then we'll talk about how the RV, but it not always, not all. RV does not. This patient, what I did is he had a severe RV failure, and the cardiologist told me, no, don't take him. He will die. Your cardiologist was hesitant, but I took this patient, and once he had an anuria. Once we put this patient on cardiopulmonary bypass, believe me, he was on tons of vasopressor support, and he was on Lasix support. There was no improvement because there was no cardiac output. Once we put the patient on cardiopulmonary bypass, he made a tons of urine, liters of urine, and when we closed, his RV was much better after closure of the septum.
Yes.
Okay. Yeah. So RV does not always. It is not an always that whether we should operate or not.
Okay.
So, okay, clear?
Yes, yes, clear. I'm just asking.
Because this is acute RV failure. Okay, okay. Unless you
Yes.
have an RV infarction, it is different. You should not mix it. If you have an RV infarction, don't operate because RV will not recover. This is just a volume. When you stop the volume, RV has a chance to recover.
Because of the shunt, but RV infarction,
Yes,
this
yes.
is different.
But
story.
RV infarction, yes, it is different story. If you have a large RV infarction, I think you should be hesitant. Maybe this was your question, right? Okay. So RV infarction, I don't operate. So X-ray chest, I think it is a baseline just to do X-ray and ECG. They are non-specific. Echocardiography is a cornerstone of your diagnosis. It's very, very important. Transfluorescent, pulmonary artery catheter may be placed. You know, it is not a must, but you can put it, and we'll see next slide. Coronary angiography with left ventriculography. Nobody does ventriculography because already echo is enough to diagnose nowadays. Coronary angiography you may need because you may have to revascularize at the same time. And CT or MRI, particularly those chronic, stable, or recurrent VSR after the surgery, CT and MRI is not a routine investigation for diagnosis. So,
Dr. Shabir,
yeah.
and in the book, they don't recommend putting pulmonary artery catheter. They feared from perforation of the fresh infarcted myocardium. This is something we have to fear of, or just
okay,
just theoretically.
Yeah, it is like, as I was saying, this is a cases, right? So everybody who writes this article, maybe he has seen some complication and that is why he writes it. But I have not come a single case where there was a pulmonary artery catheter was put and there was any perforation. If you are a good and expert, you can put a 7-Ganners catheter and push it into even in the cath lab, or it is very soft. I think it is such a, you put have you seen putting the PA catheter?
Yes.
Yes. So it is, as you see, it is so soft catheter. You put a balloon and it just floats. How do you put a PA catheter? It just floats. It is just a blood pushes it to the PA catheter, right? In the PA, in the pulmonary artery. There's no pushing. You just float the catheter, inflate the balloon, and gently, it is a blood which pushes it. So very soft catheter, blood pushes it. It is a flow directed catheter. So it is not a wire like, wire. I definitely, if you put a wiring of something, it can perforate definitely. I don't think a PA catheter personally should, but it can go into the LV because of this, rupture in the septum. But if you are an expert, you can put it. It is not a must, as I said, we hardly put it, but usually we put in the cardiogenic shock patients in the OR, because it helps us in the post-operative management in these patients, sick patients.
Thank you.
So, as we see, chest radiography is not just gives any heart failure, acute heart failure like edema or congestion. ECG is again not it is non-specific. You may see again the ST changes, or you may see the other non-specific myocardial infarction changes, but nothing specific to the VSR. Persistent ST elevation is usually seen in the LV aneurysm, putting pseudoaneurysm, which will study in the coming presentation. So I think most important thing is echo. The echo, what happens? You can get an accurate information in terms of the location of the VSR and size of the VSR, associated ventricular motion abnormalities, whether there is associated mitral regurgitation or tricuspid regurgitation. You can quantify or qualify the left ventricular, right ventricular size and contractility, and you can have a detailed study. You have associated even pericardial collection because we may have a perivalve rupture associated. So these mechanical complications can be in a combination. So I think echocardiography is a very, very important diagnostic tool. This is the patient what we will present in our, this is a case. So you can see he had a short axis view. We can see there is a defect and a large shunt is going across the VSR. You can see this one. There's a big shunt passing through this. And again, the same thing. This is another view showing the same defect. There's a dropout here and the shunt passing from the left to right. This is not this case, but this is a different case. As I showed, you can have the complex VSR. This is one of my patients. We did it. I had a whole septum was necrosed and blood was flowing within the septum. And this is another case. You can see that shunt is going from, it is hugging the right ventricular wall here, and you can see there is a defect here. This is one of our patients here. If you see, there is no big shunt, so the RV looks better. But if you concentrate here, LV is already moving. His ejection fraction was around 15%, and he had a large aneurysm, anterior aneurysm. It was a true aneurysm. He presented late presentation, I think 2 weeks or so. He was heart failure, but he was relatively stable, because I think he had a chronic issues. LV was down definitely, but RV was kicking nicely. And there was a shunt. I don't know what was a significant, not significant, but we took him into OR. He had an uneventful recovery. I will show the operative photograph of this patient as well. As you said, Swan-Guinness pulmonary may be introduced. It is not a must, as you said. You can at bedside, or you can do in cath lab, or you can do the OR. It just will reveal your step of oxygen saturation in the RV, and you may quantify what is the amount of the shunt, or even when you put in the wedge pressure can be seen, which reflects the left atrial pressure and eventually left end-systolic pressures, and pulmonary artery pressure are usually elevated because it is an acute setting. So it is not a must, but it may be a little bit helpful. Coronary angiography, yes. I think if the patient is stable and you have a time, I think you should do a coronary angiography. In patient undergoing surgery, coronary angiography should be performed. The reason of the most important is because if you do revascularize the heart same time, they have a better outcome than the patients who only have the VSR repair. So I think you should do a coronary angiography if the time allows you. In case of severe coronary artery disease, additional coronary artery bypass grafting for surgical closure of the rupture should be performed. It is in guidelines as well. On occasion, in catheterization laboratory, left ventricular ventriculography will help confirm the presence of VSR. If some cardiologists may put some dye in the LV and check the VSR. So what are the angiographic findings?
Dr. Shabir?
Yes.
Sorry for interruption. You said if the time allow me, so if it's patient hemodynamically unstable, I can skip this investigation?
Yes.
I can.
Yes.
So I will not do revascularization anymore, only fix the VSD and I will go out.
Yes. Try if the patient is, if you want to take him, it is a salvage, patient is really shocked. He is absolutely, unstable, the lactate is going high, his anuric, as our case was there, but we diagnosed him after they did an angiography, he crashed. So if the patient is crashing, there are two scenarios. Either, again, there is always a case by case wise, you have to take decision in these cases. If he's a young, 40 years old, and is doing very, very unstable, just take him to the OR, put an IABP and take him into the OR. And this is very important. If he has 80 years and has some comorbidities, you may be hesitant. So, but I will, if somebody will give you a case scenario, but take him right away to there, because you can say more than 50%, around 50% of the patient have a single vessel disease. Okay. This is one in your favor. The second thing is, there are good number of studies, those small, these are always small studies where they have seen there is no benefit. But the guideline is recommend that you should do an angiography and you should revascularize the coronaries as needed. But the case scenario depends on the case.
In case he's hemodynamically unstable, I decide to take him to OR without angio and patient survive. You will do coronary angio after the OR?
Okay, now the patient is, you did VSR, you thought, you let us do him, let him come out of, let him go to the floor, let him recover. It is better before discharge, you take him to the coronary angiography. Yes.
Okay.
Yeah. So what are the mostly, that is what I was telling you, ventricular septal rupture may be associated with multivessel disease. It may be have a high prevalence, more than 50% of them have a single vessel disease. Okay. So ventricular septal rupture likely to be associated with total occlusion of infarct related arteries. The issue is in VSR, what happens if suppose most of the cases in the LAD and RCA, so let us take an LAD, it is already infarcted, you don't revascularize. When you repair your LAD, whole area is infarcted and it is excluded from the LV. So it will not give you benefit. Only thing that suppose the LAD area is infarcted. So what you revascularize, you may revascularize the circumflex OM, or you may revascularize the RCA. You will not revascularize the LAD because most of it is gone. This area is already dead. This is total occlusion. So that is why there are conflicting results. Some studies say it is better to revascularize. Some say it didn't change any benefit. But the guidelines say it is better to do angiography and do revascularization. So what is a medical management? Always we start with medical management. As we said, we have to put an IABP, put some support, some inotropic support, give some guarded fluids, and vasopressor support. So medical management is routine by a cardiologist, so we will not discuss it at all. And some patients may need a mechanical circulatory support system like perioperatively, particularly IABP. All of these patients who are borderline, you should put a mechanical IABP. ECMO is not a must, but ECMO may be needed in those patients who are not going right way to the OR because of some other issues. So ECMO can be put on those patients. But where you are planning to take the patient in OR in a few hours, it is always advisable to put the patient on immediately on an IABP. It definitely helps in these setup of the patients. Surgical repair is the cornerstone. Yes, without surgery they usually die. So surgical repair is the only hope in these patients. And percutaneous device closure may be considered in a very selective patients who are not surgical candidates, who are futile to take them to the OR. And also in those cases who are doable by the every case cannot be done by the percutaneous device. So when should you take? Very, it is a controversial question. When should we operate them? Although the surgical mortality remains very high, non-surgical mortality is certainly more higher. Thus, the clinician must weigh the known risk of surgery against the unknown risk of postponing the surgery and developing further clinical deterioration. So it is your call whether you should take him or not. It is very important to wait or not to wait. So, but what does the guidelines say? This is 2004, AHA guidelines, ventricular septal rupture after STEMI, class 1. Patients with STEMI complicated by the development of VSR should be considered for urgent cardiac surgical repair, unless further support is considered futile because the patient wishes or contraindications or unsuitability for further invasive care. So you have to prepare for, as per this guidelines, you have to take him to the OR unless other things come in place like patient does not want or contraindication or unstable. CABE should be undertaken at the same time as repair of the VSR. So in 2013, the AHA again stands that emergency surgical repair is necessary even in hemodynamically stable patients because the rupture site can expand abruptly, resulting in sudden hemodynamic collapse in previously stable patients. So they did not change in 2013. But European Society of Cardiology, there is a little bit change. They recommend early surgery should be performed in all patients with severe heart failure that does not respond rapidly to aggressive therapy. Delayed elective surgical repair may be considered in patients who respond well to aggressive heart failure therapy. So you can wait if the patient is stable. This is important slide here. 30-day mortality for VSR with immediate surgical management at or at various points of time. If you have an acute MR and with VSR, if you take the patient into surgery in the first 24 hours, you can see the STS data showed 60% will die. Percutaneous, even the mortality is higher. But when the surgery is done 1 to 7 days, the mortality comes lesser. In the gastro trial, it showed 47%, in STS 54%. If you keep on waiting, in the second and third week, almost the 30%. And after third weeks, the STS shows 10%. And eventually, but if you do not operate them, but we don't know surgery defer, unknown percentage of mortality while waiting for surgery. We don't know how many patients die usually. So if the patient is, the bottom line here is, if the patient is stable, better to wait. If the patient is unstable, there is no way you have to take him to the OR unless contraindication. Because the waiting, eventually the 94% of the patients die in 1 month, as has been reported in the gastro trial. So you have an acute my VSR, it is hemodynamic unstable. You can go for immediate surgery if he is qualified for surgery. If he now another option is percutaneous closure in those where the anatomy is suitable for percutaneous closure or unlikely to be a surgical candidate in the future. So you can try percutaneous closure. Or the patient is really, really sick and you do not want, such patients can go ECMO and delayed surgery. Once his multi-organ, his kidney and other things start recovering, then you can take him after a couple of days or 2-3 days, you can take him to the OR. If hemodynamically stable, but still with a large VSR, but he is rock stable. So you can consider close monitoring with afterload reduction, IABP, ECMO and delayed surgery, maybe after 7 days. As we saw, after 7 days, the mortality is really, really low. So hemodynamically stable is small VSR. Yeah, I don't think you should take him to the OR. It's a very small VSR. There is no significant shunt. So you can just put in conservative management, or you can do a delayed percutaneous closure. Or if he's not candidate for percutaneous closure, you can almost electively operate this patient. So surgical techniques, basically, there are 2 techniques which are popular. One is Daggett technique, which is an infarctectomy. It is a double patch or single patch, closes the VSR by a patch over the defect after infarctectomy. So we cut some muscle which is necrosed and switch the patch to the right and LV. So you can put a double patch or the single patch, but the stitches are from the RV to LV or LV to RV, but we remove the most of the infarction part in the septum. In David technique, it is an infarct exclusion technique. All sutures are placed on the LV side, and we do not touch the infarction. Most of the time, we do not touch any part of the infarction. So the principles of infarctectomy repair of post-infarction VSR are the David technique, trimming of the left ventricular margins of the infarct back to the viable muscle, closure of the septal defect without tension, and buttressing of the suture lines with plagiatus or strips of Teflon to prevent suture from cutting through. If you can see this image, this is a patch and this is the septum, and we put it is coming from the RV and then going to the LV side of the septum and then through the patch. And here you can see this is the RV part and this is the patch in the anterior part of the septum. So basically, we cut the most of the necrosed muscle. I prefer doing an exclusion technique, which is, I think, is the better technique and has shown better results. We do not touch the necrosed muscle. Pericardial patch is sutured with continuous prolene suture around the defect to exclude it from the LV cavity. Full thickness bites are taken to the epicardial surface and anchored by strips of pericardial Teflon. Anterior patch is anchored to the non-infarcted septum below the defect. Then the non-infarcted anterolateral ventricular wall. We'll see these images. I will show how I do it. And posterior patch is anchored to the mitral annulus. non-infarcted septum, posterior wall along the line corresponding to the medial margin of the posterior papillary muscle. I understand this is a little bit, difficult, just theoretical part, but these are the general principles, how we do it. And closure of the infarctectomy usually strips of pericardium or a Teflon. Infarcted right ventricular free wall is left undisturbed during the closure. So how I do it? This is the case which we presented in the first slide. So we took him to the OR right away. So usually cardiopulmonary bypass with bicaval cannulation, moderate hypothermia, and then integrate blood cardioplegia. We give all patients this. When vent is put through the right superior pulmonary vein, and distal coronary anastomosis. If you have an angiogram and you want to, we do it first before we going through the VSR repair. So next setup, we do a left ventriculotomy. If you see, we open this ventricle around 2 centimeters away or 1 centimeter away from the LAD. Then we put a stitch sutures here. These stitch sutures help in exposing the VSD. Then we usually take a large pericardial patch, 10 by 5 centimeters, available in our hospital. It is tailored to the shape of infarction. Then you keep on a little bit trimming this patch as needed, as per the shape of the VSR. If you can see, we have put a retraction sutures. Now you can see the VSR is looking. You can see this defect, a huge defect in the septum, anterior septum. Patch is then stitched to the healthy endocardium, away from the edge of infarction. I use a trioprolene suture. So it has to be way away. I usually put it at the bottom, close to the bottom of the septum. You can see in this, now I reinforce these stitches with the pledget sutures, and it is very close to the bottom of the septum. So stitch sutures are the posterior infarct part of the healthy septum. Wide bites are taken with trioprolene sutures. Do not pull too hard. Reinforce with interrupted mattress pledget sutures. Upon reaching the proximal and distal parts of anterior septum, I exteriorize these sutures. You will see in this. Now I came out. So this is the RV, this is the LAD, and this is our incision. So it is on the left side of the LAD. So when you stitch this patch on the bottom, now you come anteriorly. So you put your stitches from in to out here. So here also you reach out. So then is the second step is to stitch this patch to the anterolateral wall. So this is healthy. So most of the time you exclude this whole infarcted area is excluded. So another important thing is make sure the patch is not under tension. Little bit redundancy of patch is good to avoid the tension and tearing it, and it also helps the filling of the LV during the diastole. Now your LV is little bit smaller, but if you keep it redundant during the filling, it helps in the filling if your patch is little bit low, a little bit redundant. Then we close the ventriculotomy is closed in 2 layers or two strips of Teflon felt using the 2O polypropylene suture. This is the same patient, the same case what we discussed in before. So this is the patch, this is the RV. So this patch is from the bottom here, and how it is looking up on the echo. See. So the defect, we didn't touch this any of the infarcted area. This is all infarction, but it is a little bit redundant. So, but it helps us in the diastolic filling. And if you'll see, then this patch, there was no shunting. It was just stopped because this patch, there was no shunting. It was a huge VSR. Basically, if you will closely monitor, there is hardly any shunt across the septum. This is one of our cases, I did a VSR with an ASD. I have never seen any case report. It was just a case report because he had a large ventricular, he had a VSR plus ASD. And he was a stable basically because the RV is prepared. It is already trained because of the high volume, because of the ASD. So this patient was relatively easy to do. And then I put an ASD patch here. This is how, you can say VSR and ASD same time. This is one of our patients who had an VSR and had a large he had an aneurysm. So what cardiologist took him to the cath lab, and then he was trying to, put him, because he was stable. He presented around 2 weeks. He said, no, I will put a percutaneous device closure. So he couldn't pass the wire. The reason was that there was the serpentine course. You can see the whole septum. There was a tract within the septum. It was not a through and through. So this is whole aneurysm, and this is the VSR, and it was at oblique course, so he could not wire it. So then he failed. I took him from the cath lab directly to the OR. So what we did, we put a patch here, we put a bottom of the septum here, and then we came anteriorly. I came to the anterolateral wall, and this is whole aneurysm which was excised, and this is how it looked at the end. Very awkward, but this patient had a very nice recovery, alhamdulillah. I think let me show this. Okay, this is the same patient what we are discussing. We'll show a short video here. I think we saw these slides. I just want to show you how it look. So how it looks. It is an acute acute myocardial infarction. It is hemorrhage. You can see there is flimsy adhesions, but it was a very, very frail myocardium here. So what we did we cut it. We made this one parallel to this one. LED, we cut this is all infarcted myocardium, so you should not worry, what will happen. You do a liberal incision and cut it, because it is all dead. It doesn't contribute anything to the myocardial function now. Then put retraction sutures. It helps us in exposure of this VSR, as we described in our slides. So then you can see the VSR is the same case. It is a huge VSR in the anterior septum, mid-anterior septum. And this is the apex, and this is the base of the heart. Then what we stitched this patch, pericardial patch, bovine pericardial patch, and this is the infarction. Most of the infarction is this side. So we will exclude this whole infarction. We will exclude this part. Then we come to the anteriorly. We stitch from inside and of the septum, and then fix it into anterolaterally. This is anterolateral now, from inside to out. LV cavity is a little smaller, but if you keep the patch bigger, it will help in filling the diastole. This is the end, how we close it, and then we run back and put the cardiopulmonary bypass off. So surgical review outcome of this patient is, so this is a very important, I think, landmark paper, which was written by Tyrone David in 1995. And he did 44 patients, and 29 patients were in cardiogenic shock. And very interesting finding is only 6 operative deaths. A very, very great outcome. I have not seen any such study so far which had such an excellent result. So what interesting was, he did an infarct exclusion technique. What is infarction? See, he put in the bottom of the septum, which is healthy, and then he put in the anterolateral wall of the LV. So this whole infarcted area is excluded, and this is the LED. What I do not do here, because I think this will cut through. So I put a stitch here and bring it out, so that it anchors nicely. It doesn't cut through. This is the only difference what I do. This is another patient, another modified infarct exclusion technique. It was recently published in Annals of Thoracic Surgery in 2019. I think what they put a double patch. They put a bottom here and bring it out, and then stitch here, and they put another patch which is connected to the previous patch, and then bring it to the anterolaterally, and then put a stitch together. They reported that they had a less recurrence of a residual VSD was less. I'm not sure. This is an interesting, shock trial registry. In this registry, 939 patients, but 55 patients whose shock was associated with VSR. So the patients who had a shock due to VSR, they had an 87% mortality compared to the shock who had without the VSR. Surgical repair was performed in 31 patients, and out of these, only 19 survived. That means they had an 81% mortality. And the medical treatment was done in 24 patients. I think all died except one. So it has a pretty bad outcome here. This is Sweden, national registry. They did around 189 patients, which is a good number of cases, and the mortality was again, around 41%, and survival was relatively just 38% at 5 years. Interesting in this paper was, if you operate early, as we saying from the beginning, that the mortality is more than 60%. The more you wait, the better is the outcome. But during this waiting period, you may lose the patients. That patients are not usually counted. This is another interesting paper, which was in 2009, in a 25-year experience, 102 patients, very good number of patients, which a 30-day mortality was 33%. Initial period in their experience was 45%, and recently their mortality was 21%. This is an important article, which is from the STS database, and it was reported in 2012 in Annals of Thoracic Surgery. In this, there were 1999 to 2010 data, and our primary outcome was the operative death. And this has a 2,876 patients. This is the biggest case series from the STS data. If you see, the operative mortality was 54% if the repair was done within 7 days, and then 18% if it was done more than 7 days. If you see, from 1999 to 2010, there was almost number of procedures stay constant. This is only half of the year, I think part of the 2010, that is why we don't see the full year here, but it was a number of procedures were constant over a decade, and operative mortality also did not change much. If you see, it is almost 40% or even higher over the last decade. Interestingly, again, in STS data, we come across the mortality is higher if you see the first few hours, and then keep on decreasing. If you do more than 2-3 weeks, then the mortality is hardly around 10%. So in this STS data, the common following risk factors for operative mortality: the age, the elderly do worst, females do worst, patient who present in shock, patient is in inferior infarction, they have a worst outcome, because this is technically also very challenging. And if you have a preoperative like balloon, they are preoperative dialysis. If you have associated mitral insufficiency, redo cardiac surgery. If you do emergently, this patient taken in the and I think timing of repair is the most important risk factor for the mortality. I think we'll bypass this one, triple patch. This is from this study from the Brazil Journal of Cardiovascular Surgery. They did a 55%, 40 were operated, 21 died, and only 19 survivors, 54% mortality, and 5 elective device closures, all survived, because obviously they are very stable and have a small shunts. And those sick patients who were not operated, all of them died. I think this is again another publication. Is recently 2018, Interactive Cardiovascular Thoracic Surgery. They did a 39 patients, and their ventricular septal defects interior was 54%, posterior was 46, almost balanced, and 31% underwent concomitant cardiopulmonary bypass. So interesting in this study was the 30-day mortality was 36%. The 30-day survival was higher with than without coronary concomitant cabbage. So if you do a cabbage, you have 56%. Without cabbage is 56%. With cabbage is 83% survival. So it is better to operate and do a cabbage at the same time. So mortality overall was 36%. I think we went through this slide. Oh, recurrent ventricular septal rupture, it is another issue in these patients. Recurrent or residual septal defect happens in 10 to 25% of the patients. So how do you manage this patient? The large residual septal defect should undergo a repair. If there is a small defect, it may be managed medically and may occasionally close spontaneously. Percutaneous approach for these small residual defects have been preferred when possible, and surgical closure of late postoperative residual defects have been reported via right atrial approach, as we do in the pediatric patients. What are the general principles of the percutaneous closure are? Most authors suggested that a defect of less than 15 mm is optimal due to the device size that are available, as well as the size of the septum. Inferior and posterior defects are especially challenging as they frequently lack an adequate tissue rim to secure the device. Serpiginous defects are not only difficult to cross with wire, as we have seen in one of our cases, they failed to pass the wire. And freshly infarcted myocardium exhibit ongoing necrosis, making peri-device leakage or even device embolization a concern. These are the some studies, summary of the major trials of percutaneous device closure. And you can see the 30 patient, 12 patients, 19 patients, 11, 18 patients. I think important is the timing of when you intervene. So if you see here, if you intervene in first day, 1 to 3 days, 88% die. In this, 2 out of 10 patients, there was a 100% mortality. So the percutaneous closure is an evolving therapy, and in selected patients may be very useful. So home take message from this VSR: most myocardial infarction when VSR is rarely but potentially fatal complication. Surgical correction carries highest mortality among all cardiac surgical procedures. Clinical presentation predicts the outcome. The treatment strategy should be individualized according to the patient's clinical status and hemodynamics. The successful surgical outcome depends on the prompt recognition. And thank you very much. So we finished the first part of our presentation, which was a VSR, and I think we can have some questions if you guys, then we can go to the next presentation, pre-wall rupture.
Thank you, Dr. Shabir. Floor is open for the question.
Was my voice clear or what?
Yes.
Okay, thank you.
Any question from you guys?
Thank you.